By June 2021, during the pandemic, there were marked differences in COVID-19 vaccination rates related to ethnicity, deprivation, and geography. Directors of Public Health and local authority staff's role was to support the NHS vaccination programme and maximise uptake, specifically for those from disadvantaged groups. We interviewed directors of public health and other local authority staff in England about their experiences of trying to increase vaccination uptake. Public health teams reported that although some people were frightened and concerned about the COVID-19 vaccination, the major issue was in fact access to the vaccination.
What we've noticed through some of our street conversations, it's not hesitancy as such, it's finding the space and time and energy to go and get vaccinated. So we've been trying to make it as easy as possible.
The findings show a clear division between central and national government and local authorities that had negative impacts on the ability of local public health teams to respond flexibly. Decisions were made centrally without considering the skills, knowledge and experience of local teams and their established links with communities.
The mass vaccination sites are only going to work for a finite amount of the population. More deprived communities just go about their lives, and you need to integrate this with their life. That wasn't always recognised, apart from at the local level, where you've got your ear to the ground in terms of what's working and what's not working.
Local teams needed detailed local vaccination rate data. Data was held centrally, but access was restricted. Many teams had to patch together data from different sources to identify low uptake.
The government have given us by name and address the number of people who test positive on a daily basis. We wanted that for the vaccine as well. We weren't able to get that, and we still aren't able to get that.
Vaccination target rates were set centrally. This created tensions between meeting the targets or spending time and effort reaching disadvantaged groups with a greater need.
Targets for vaccination programs need to focus on inequalities. What have you done to particularly enable groups with protected characteristics to access vaccination? Because we've offered everybody is not enough.
How much general practices were paid for each patient vaccinated was decided centrally. General practices in affluent areas with high uptake received the same amount as those in deprived areas who had to do more to encourage their patients to be vaccinated. In conclusion, the key message is national and central should consider the differences across localities and communities and draw upon local expertise and knowledge when developing and implementing public health policy.